This is Where We Live from Connecticut Public Radio. I'm Catherine Shen. Public health experts are concerned that vaccine-preventable diseases are popping up in communities across America. Measles is now in more than 40 states and jurisdictions across the country, and the majority of patients were not vaccinated. That's according to the CDC. 2 unvaccinated children in Texas and an adult in New Mexico, who was also unvaccinated, had died. It's the first measles deaths in our country in 10 years. Meanwhile, last week, a key CDC committee under Health Secretary Robert F. Kennedy Jr. rolled back longstanding guidance on hepatitis B vaccinations for newborns. Joining me now to dig into the history of vaccines in America and what we've learned or haven't is Jason L. Schwartz. He's an associate professor at the Yale School of Public Health and also teaches the history of medicine at Yale University. Thank you so much, Jason, for joining me today.
Thanks for having me.
And for our listeners, let us know if you have any questions or stories that you'd like to share with us, 888-720-9677, or leave us a comment on Facebook and Twitter at Where We Live. So, Jason, you're a public health researcher on vaccine policy and also a science historian. So can you tell us, what was America like before vaccines?
For each of the vaccines that are now on our recommended schedule, there is a long history of suffering, to be frank, suffering of children predominantly that even our older practicing physicians look back on and recall, frankly, with horror, what pediatric emergency rooms may have looked like, as recently as the 1980s and 1990s. So the story of vaccines is one in which there is a history of public health triumphs that have developed new effective tools that have prevented suffering, prevented hospitalization, prevented deaths. And for each of the vaccines on the schedule these days, we think about kids who don't have to experience what generations ago were a common and often very severe aspect of childhood.
Mm. And we mentioned earlier that during the measles outbreak in Texas, that the federal government responded by sending extra doses of vitamin A to prevent mortality, which vitamin A does not do. And a small group of children were admitted for vitamin A toxicity, and after 2 unvaccinated children had died, Health Secretary RFK Jr. did sort of an about-turn. He said the MMR vaccine is crucial in preventing measles. So there's been a lot of back and forth in terms of this, especially with this conversation. And how is this misleading or can be confusing to people?
Right. Well, measles is always such a really important example of sort of the well-being of our national vaccination system, just because of how incredibly effective measles is at finding vulnerabilities in our public health safety net. And typically when there's a measles outbreak, and we see them repeatedly, and we have for decades generally in unvaccinated individuals, you will see public health officials shouting from the rooftops that vaccinate, 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 because of what an important, safe, and effective tool measles vaccination can be in all cases, but especially in an outbreak. And you're right that one of the many departures we've seen over this past year, given the shift in the federal government's view and posture towards vaccines, is a far more, kind of frankly muddled discussion about the central importance and value of vaccines. And I think we saw it during these measles outbreaks, and we continue to see it in this sort of arm's length relationship at best that vaccines play in how we talk about the best way to keep our children healthy.
And this is a theme that will be returning throughout this conversation this hour, but curious to hear, especially based on what you're seeing and what you're hearing. And you mentioned just now, too, that, going back to the 80s and the 90s, which is not that far back, that there has been a lot of prevention but outbreak at the same time. So how far back does it go in terms of us seeing vaccines working?
Yeah, the story in the 20th century was one of remarkable advances in our vaccine technology and our expansion of our vaccine toolkit. That if we go back before the 1950s, we could prevent smallpox, which we've thankfully eradicated. We could prevent diphtheria. But by the 1950s, that incredible triumph of the polio vaccine that was global scourge and an eagerly awaited development, really ushered in an era of advances in vaccines that accelerated, continuing to this day, with the measles, mumps, rubella virus and vaccines that were developed in the 1960s, and then the whole host of vaccines that came to be over the last 30 or 40 years. So the vaccination schedule has developed over the past 40 or 50 years, and we've turned to our public health communities, especially the Centers for Disease Control, to help us understand how to best use this expanding array of tools. So it's a story of successes, a story of expanding abilities to prevent a broader array of diseases, and one that really has been with us, thankfully, now for the better part of the last 50 years.
Well, and coming back to the present, too, in terms of what we're seeing today, in Florida, Governor Ron DeSantis had advised parents to send their children to school if their child had measles. And so this idea is to infect the entire class in a natural way. And this is something that has been sort of in conversation for a long time now. But what do we know from history about this experiment?
Yeah, we've heard about this with measles. We've heard about this with chickenpox or varicella. This idea of the alleged superiority of natural infection as being a superior alternative to vaccines for skeptics of the value or safety of vaccines. That has come up with respect to measles. It comes up for many decades now, and it's deeply concerning because, of course, these diseases, even though in many cases in the past, diseases like measles were mild and self-limiting, as physicians would say. That's not always the case then. It's certainly not always the case now, as we know that 10% of measles cases result in hospitalizations. There have been deaths, as you mentioned as well. So the idea of deliberate or natural infection with the risks of the disease that comes with it, is a long-standing but a really high-risk alternative to vaccines that, in many cases, the measles vaccine most especially, has a 60-year history of use for billions of doses, extensively tested and studied, and a record of success that matches that long history. So the risk-benefit calculus, as one is thinking about it, clearly, by any reasonable measure, would point in favor of the vaccine.
Well, and of course, school vaccine mandates have also been at the forefront of our minds for many years now. And Florida Surgeon General Dr. Joseph A. Ladapo on his plan to end school vaccine mandates. So he told a crowd in Tallahassee this past September that every last one of them is wrong and drips with disdain and slavery. Who am I, as a government or anyone else, to tell you what you should put in your body? So, Jason, could you talk about what he said and also how that may impact the way people think about vaccines?
Right. For as long as we've had vaccines, and this goes back to the 1800s, public health officials and governments have turned, in some cases, to requirements, to mandates, to promote the public health, to ensure high rates of vaccination. We do that routinely here in the United States, including here in Connecticut, usually linked to school attendance. And it's seen as a really valuable safety net for our vaccination programs to ensure that kids do receive the vaccines for which they're able to benefit, to protect them and to protect our communities. But these requirements throughout their history and certainly today have always been a lightning rod for controversy, for concern, for criticism among opponents across the political spectrum, but increasingly these days from right-leaning or Republican skeptics of vaccines. So I think we are seeing lots of activity. Florida, most notably, the Supreme Court looks like they may be weighing in on details of the vaccine requirements in New York State in terms of the availability of different kinds of exemptions. So we have turned to these requirements really since the 1960s or 70s as a component of our vaccine safety net. But I think there's no doubt that they continue to be a real source of contention and criticism. And I suspect we'll see more action, not just in Florida, but in other states in this really turbulent period for vaccines.
Well, in the school space, it sounds like you just mentioned from the 60s and the 70s. Is this something that you've seen or heard that has always been sort of contentious in some way?
Absolutely. And I think these requirements, as we see them today, linked to school attendance, emerged because of measles outbreaks in the 1960s. The measles vaccine was relatively new then. Measles was so highly transmissible then and now that it was quite clear that schools with high vaccination rates against measles had fewer measles cases than schools that did not, and that the requirements were a tried and true and effective way to ensure those high vaccination rates. So that set the stage for the expansion of these school requirements to include other vaccines here in Connecticut and elsewhere in the decades that came. But certainly they engender all sorts of concern among parents who feel as if their decision making is being usurped by these requirements and infringing on how they decide how to care for their children. So I think to the degree that vaccine safety has been a perennial source of anxiety and fears around our vaccine programs, the use of these mandates or requirements, I think, is probably the second leading issue that we see again and again in terms of the public discourse around vaccines.
Well, and coming out of the school space, has our country always been this divided on party lines when it comes to vaccines? Is there anything different now compared to the past?
Yeah, no, there's definitely a really post-COVID story to how partisan attitudes around vaccines have become. That there has been criticism and concerns around vaccines, certainly for centuries, but it kind of crossed party lines. It was a big tent of folks who may have, in some cases, had concerns around sort of that libertarian critique of parental rights being infringed upon by vaccines. But there were others who were opposed to vaccines who questioned the chemicals or the things that were included in vaccines, or the role of big business in promoting or perhaps profiting from vaccines, or people who prefer just a more natural lifestyle. So there was a sort of a broad constellation of views that might align with skepticism or hesitancy towards vaccines. Some of that remains, but certainly coming out of the COVID pandemic, polling and just public conversation has signaled that there's a much more significant focus among the Republican-leaning voters or Republican elected officials who increasingly express concerns about vaccine policies, about the safety of vaccines. So it's taken on a really unsettling partisan character just in these past 4 or 5 years.
You've been listening to science historian Jason L. Schwartz, and he'll be staying with us. Coming up, the state's top public health official joins us to talk more about vaccines and how the state is reacting to changing guidance. Let us know if you have any questions about shots for yourself or for your loved ones. Give us a call, 888-720-9677, or find us on Facebook and Twitter at Where We Live. This is Where We Live from Connecticut Public Radio. I'm Catherine Shen. States, including Connecticut, are crafting their own vaccine recommendations in response to changing policies, federal policies. The Connecticut Department of Public Health is led by a Yale-trained infectious disease specialist, and the agency is developing a vaccine policy that's very different from the federal government's. But the challenge, the agency says, is to gain public trust amid conflicting messaging. And in a moment, we will be joined by Dr. Manisha Jutani, who is our state public health commissioner. But first, I want to bring back Jason Schwartz, who's an associate professor at the Yale School of Public Health. And Jason, you and I, we've been talking about the history of vaccines here in America. And of course, this is, as we mentioned, a theme that's going to be continuing throughout this conversation. But I'm curious to hear, what are some of the biggest changes that you've seen since you stepped into this space, compared to history in the past to the present?
I think it's really what we've seen over this past 11 or 12 months, to be frank, where while there have always been those with concerns or skepticisms or critiques around vaccines and vaccine safety in particular, generally there was a strong coordinated, organized public health apparatus to help communicate and respond to those concerns. And what we've seen over the past year is that many of those most vocal, strident critics of our vaccine policy are now leading some of our nation's public health agencies. And that's created enormous challenges for our public health system and how we think about vaccines.
Well, perfect segue to talk about our public health department right now, joined by Dr. Manisha Jutani, who is Connecticut's Public Health Commissioner. Dr. Jutani, thank you so much for being here.
Thanks so much for having me.
So I want to start here by talking about how doctors across Connecticut are saying that more patients are declining not just vaccines, but medical interventions in general. So I want to take a moment to listen to a comment from Dr. Christopher Morosky, who's a OBGYN at UConn Health, and our health journalist Sujata Srinivasan spoke to him about parents of newborns turning down interventions that used to be routine.
If you were to say it's a 10 to 20% increase in declining erythromycin ointment in the eyes, vitamin K shots, and hepatitis B vaccine, I think that is a pretty accurate estimate.
So, Commissioner, can you respond to what we just heard from Dr. Morosky? What does that mean, really?
Our public is hearing information from the federal government that is confusing. And at the end of the day, people are trying to do right by their children. People truly love and care for their families. And they are trying to navigate a confusing system in trying to figure out what is the right thing to do. And sometimes that means do nothing. And doing less interventions, people seem to feel might be the safer way to go when you really don't know how to evaluate the evidence. And I think one of the challenges that we're faced with right now is that although there's always been a system of a back and forth with physicians, a back and forth with a provider in terms of asking and trying to get to the bottom of whether an intervention that is being proposed to you is the right one for you, and then ultimately your choice. We're now faced with a lot of comments that make people untrustworthy of everything in the medical establishment. Now, the challenge with that is that when you are in crisis, when you are truly sick and in distress, you have no choice but to put your faith in the medical establishment. And people who have been in that situation more often than not are quite grateful for more often than not positive outcomes. Obviously, there are times when things don't go the way we want them to go, but it is that same science and foundation that goes into treating acute situations and things when people need it most, that goes into preventative medicine and things that help prevent worse outcomes. And in public health, a lot of times I say that our greatest successes are unfortunately our greatest challenge right now, because our successes is when things don't happen, when people don't get sick, when people don't have bad outcomes. And unfortunately, it's feeling like people need to see what we're preventing to truly understand why we are advocating for prevention.
Well, I want to give you a scenario here. As we mentioned earlier, there's been a lot of conversation happening right now in this space, and Health Secretary RFK Jr.'s vaccine panel changed the CDC's recommendation for hepatitis B shots this week. So for 34 years, the CDC has recommended that all babies should be vaccinated against Hep B, but that's no longer the case. So the panel recommends the shot only for babies whose birthing parent has Hep B or if their Hep B status is unknown. So your agency, Commissioner, the Connecticut Department of Public Health, disagrees with this recommendation. Tell us why.
The reality is that in the United States of America, we do not have universal health care. So there are gaps in the delivery of care throughout the lifespan, but particularly in those early days, weeks, and months of life, there are babies that will leave the hospital and start having exposures in the world. It's not just the birthing mother. There may be a partner, there may be siblings, there may be grandparents, there may be others in the community who are coming in contact with that child once they leave home. And maybe for some families, it's at that first visit where they say, you know what, now I'm comfortable getting that shot. Well, that's great. If it wasn't in the hospital and it was at that next visit, terrific. But what if you don't make it to that visit? And what if the next visit to the hospital, you have 2 jobs, it's difficult to actually manage to get to the pediatrician's office? We have now missed an opportunity where we know this very, very highly infectious virus, which results in 90% of babies, if they get this virus, have chronic infection, which can result in the need for a liver transplant or chronic lifelong disease and even potentially worse outcomes. And we've seen in the history of hepatitis B vaccination in this country that the age of vaccination has become lower and lower and lower because it did not work the other way. And so I give the example that in the last 10 years in the state of Connecticut, we have had 27 cases of acute hepatitis B infection in people between the ages of 25 and 65. Now, these are adults who may not have gotten immunized against hepatitis B themselves when they were young because that was not the policy at the time. Now, imagine that one of those people is the caregiver of a child, is the grandparent of a child. So not necessarily just the birthing mother, but somebody coming in contact with that newborn who was not vaccinated. And they may not know themselves that they are infected because a lot of times it can be a silent infection for a long period of time. And it is so infectious that sharing a towel, using a toothbrush, a small nick that then, let's say, somebody puts their finger in the mouth of a child or, a small abrasion that a child has. You can think of a variety of scenarios where somebody who was infected may come in contact with an unvaccinated child. And because, again, when you think about the risk benefit, this vaccine has been tested for so many decades now and has been proven to be safe that, again, the risk benefit of giving the vaccine versus not errs on the side of giving the vaccine and recommending it. Now, again, at the end of the day, every single vaccine that a child gets is with the informed consent of the parent. That is inherent in every single vaccine that is administered to a child. There is no putting a needle in a child's leg or arm without the consent of that parent. The recommendation is to have this conversation with a parent and be able to express that you may not know even all the potential exposures that your child may have. And look, I understand there are families that are going to say, I'm negative, my partner is negative, my spouse is negative, all the grandparents are negative, I don't have any family members that have this virus, and I'm going to wait a couple weeks to get that first shot. That choice always is there. That choice is always there for families. However, as a public health department, when we are looking at population health, when we are looking at not creating barriers to care, we have to think about what is the recommendation that's going to be easiest for hospitals to implement. If we recommend it, then hospitals are more likely to just offer it right up front. If we say informed consent, if the patient is negative and we know the patient's negative, now you're asking for blood tests. You're asking for repeat blood tests at the time of birth. I know of a case in another state where a mother tested negative. She then went into labor, and it was only after delivery she found out she was in fact positive. And the baby was not vaccinated yet. It was a near miss, but they were able to quickly act on it and take care of that infant. That is the type of scenario I foresee happening more. And it may take time for us to see the impacts of that because, again, we have many people who are age roughly 35 and younger who are in fact vaccinated because that's been the longstanding policy in the United States of America. So I think this is the challenge in terms of why in our system, especially, I've heard a lot of talk about other countries don't necessarily have the same policies we do. But out of developed nations, we're one of a few that does not have universal health care. And so without changing that underlying fact, we need to think very closely about what the different scenarios may be for a given child that is being born at a given hospital.
Well, and I want to build on what you just mentioned right now, where there are so many different scenarios for different families and their children. And it sounds like, of course, we want patients and families to have these conversations with their doctors. But it sounds like a lot of doctors are leaning into the CDC recommendations. And so curious to hear in terms of there's such a broader message out here now to be given to the individuals. How does the Department of Public Health convey those messages to doctors in order to convey the messaging to families? And then in order for the hospitals to make those decisions when they have to make it based on the scenario you just shared?
The first is that we try to have clear communications with our provider community, whether it be through meetings that we have, whether it be through memoranda that we send out, whether it be with our hospitals, to have clear guidance on what it is exactly that we are recommending that they offer to patients. From our provider community network, one of the things that we did this past year after the last legislative session is set up an advisory panel of physicians and public health professionals, pharmacists, nurses, different people in the provider space who can express what they're hearing from the community and also help inform us how we can be doing a better job to be able to communicate what it is that we are recommending writ large, but then hear from providers what we can do to help them in communicating. Because at the end of the day, when we say we recommend a vaccine, we know that at the end of the day, it's the provider having that conversation with a parent, and that our recommendations are large guidance messages. But the consent and the decision to decide to vaccinate a child is done in a doctor's office, is done at the bedside. And it is that communication and trust that somebody has with an individual provider that is going to be able to help inform those decisions. And one of the biggest challenges we have right now is that there has always been some vaccine hesitancy, some segment of the population who has hesitancy against all vaccines, maybe a few vaccines. But what's happening right now is that, unfortunately, large swaths of the general public who, in general, have had faith in these recommendations are now questioning and struggling with how to make sense of all the noise that they are hearing coming through the airwaves.
Well, and as of December 2nd, pivoting to measles cases that has been confirmed. So there's been a total of 1,828 confirmed measles cases in the country, including New York, Rhode Island, and Vermont. And there has been 46 outbreaks so far in 2025. So that's comparing to 16 cases last year. And this is according to the CDC. So how worried are you about measles spreading?
So, I was asked yesterday, how quickly do I think we will see the outcomes change based on what we're seeing happening on guidance on vaccines? And my first answer is around measles. That's the exact first example to give, which is that for every disease, it might be slightly different. It might take longer. It might take shorter. But what we can see is that measles was eliminated in the United States of America in the early 2000s. And what that means is that we don't have sustained transmission for a year. We had cases, outbreaks, but they would be quickly controlled and then measles would be gone. What we have seen this year is we have seen sustained transmission with outbreaks, as you mentioned, throughout the country. There are only 8 states that have not had a case yet. Connecticut is still one of them. We've been planning for the last several years for a case. We have had cases over the course of the last 10 years, but they've been isolated incidents which have been able to be stopped in its tracks and not led to any further spread. But I do worry about this because, for example, in South Carolina, where one of the most recent outbreaks occurred, measles spread like wildfire in a school where vaccination rates were very low. And so it wasn't one child or two children. There were multiple who were infected. And that is a hallmark of how disease spreads, how when vaccination rates are low, it can impact an entire community. And unfortunately for a disease like measles, sometimes the consequences of it are not even seen until years later. So this year there was a death in California from a child, not of measles recently, likely of measles earlier in life, that resulted in the death of the child. And so you don't necessarily see the consequences only in real time. They have profound developmental effects. They have profound effects over the lifespan of a child. And so I think it's going to depend on which vaccine, which disease, and what outcomes we may see. I think one point I really want to make here, though, is that there's a reason the childhood vaccine schedule exists. The childhood vaccine schedule exists to protect children from diseases that they would normally be exposed to in childhood that we would like to prevent them from being exposed to and either having morbid conditions or even potentially dying from the condition that they may be exposed to. So there are two choices. One is get exposed to the disease and get it, or get exposed to the vaccine and develop immunity in advance of it. And so we are really playing with the lives of our children. These changes that are being made, we will see the implications of it in children, unfortunately, in the years to come.
Well, you mentioned that there's not only a decline in measles vaccinations, there's also a decline in seasonal vaccine rates in Connecticut compared to last year. Throwing out two stats here, we saw a 6% drop in flu and close to 29% drop in COVID-19 shots statewide. So how does your agency's recommendations differ from that of the CDC's, and why?
So we saw an interesting series of events happen going into this fall season. We know that there was initially confusing guidance around COVID vaccine shots. And at the end of the day, the actual votes from the Advisory Committee on Immunizations Practices essentially said that anybody 6 months and older with informed consent, with discussion with their provider, in theory could get a vaccination. That is not that different than what we were recommending, which is that everybody 6 months and older could get a shot. Again, informed consent is the basis of all vaccination. So nobody is ever giving shots without informed consent. However, what the rhetoric has accomplished is a fear of vaccines, a fear of side effects, a fear of mRNA technologies. And there are other shots, not just mRNA for COVID, as an example. And so those stats that you hear are a result of, in part, that. It's also a result of the delay in the process to get those shots approved. So we have seen a 50% reduction in COVID shots for children this season. We know children under the age of 2 who, by and large, have not seen COVID, right? Because they were not born in the pandemic. Unless they were exposed through a family member, they would not have had exposure. And we know that the severity of COVID in children under the age of 2 is much more than it is for older children. And so we will see, unfortunately, with time, what all of this means and what its potential implications are. Again, when I think about COVID shots, where roughly around 500,000 people last year got a COVID shot, and we have just a little bit over 300,000 people who got a COVID shot this year. And I think about who would have gotten COVID shots last year. This isn't the midst of the pandemic. These are people who were fully believing that the shot was either going to help them the other people in their family, their community, and was going to be able to protect them. So these are people who had bought into the idea of getting a COVID shot in 2024. And in 2025, we have not captured some of those people. Some of that is the fact that we did have a fall wave of COVID. And so even people who told me that they had COVID in September, I've said, that's okay. Wait, you can wait till December to get that shot. That might be a good time frame in which to protect you for the rest of the season or the rest of the year, potentially, even going into 2026. So this is a real challenge. We've eliminated the barriers on pharmacists being able to administer the shots. The insurance companies have said they would pay for the shots. We have recommended the shots, but at the end of the day, it's people who have to decide whether they want to get the shots. And the fact that our flu vaccine rates are 6% down, that is striking to me, that even on flu vaccine, now we've had over 1 million people get the flu shot so far this year. And we know that New York City is seeing a surge. That means we're around the corner. We're already seeing the uptick in Connecticut. I'm anticipating this is going to be the rise, and it is going to peak out through the holiday season. So if you haven't gotten a flu shot yet, this is your time.
Well, then, Jason, I want to bring you back into the conversation real quick before we go to break. Jason's with the Yale School of Public Health. I see you nodding throughout this conversation. Anything that jumped out to you that you would like to react or respond to?
I just think it's so important, as the commissioner said, to thinking about the critical role that our healthcare providers play in helping parents navigate this information landscape. That's always been true, that a recommendation from a trusted healthcare provider really makes a difference when parents are navigating a vaccination decision. But given all of the confusion, all of the conflicting guidance and messages that the commissioner noted, empowering our healthcare providers to have the information and tools they need seems more important than ever.
And really quickly, Commissioner, what should we expect from the CDC vaccine panel next?
I believe the next topic for them is going to be the entire vaccine schedule. The president has instructed the secretary to look at that. That has been a top priority for the secretary. And as I said before, I do worry for our children. I worry for our children in our state. We are trying to save them from being exposed to pathogens that used to keep children in the hospital for days and weeks. Meningitis, pneumonia, RSV. We have tools to not have that be the outcome for children. And I know parents are just trying to do the right thing by their kids, and I hate to see that we may have to see a backsliding of that trend.
You've been listening to the Department of Public Health Commissioner, Dr. Manisha Jutani. Next, we'll talk to a doctor whose patients say they are afraid of vaccine side effects. Let us know if you have any questions. Give us a call, 888-720-9677, or find us on Facebook and Twitter at Where We Live. This is Where We Live from Connecticut Public Radio. I'm Catherine Shen. Doctors in Connecticut say they're seeing more patients who are hesitant to vaccinate. Public health experts say some of that fear started during the COVID-19 pandemic and is growing as a result of vaccine skepticism from the federal government. And joining me now is Dr. David Bannock, who's the head of infection prevention at UConn Health. Thank you so much, Dr. Bannock, for being with us today.
Thank you.
And Dr. Manisha Jutani, who's our commissioner at the State Department of Public Health, and Jason Schwartz from the Yale School of Public Health are both still with us. So, Dr. Bannock, I want to start with you here. I understand that you are seeing more patients in your practice expressing vaccine hesitancy. So, what are those conversations like?
So I think we're seeing a shift in our patients. Patients are developing more questions. I think in the past, I take care of patients, mostly adult patients primarily, who have questions, and we were able to answer them relatively readily with reliable sources. And now we're seeing more questions. We're seeing patients that are asking questions about what they're reading on social media, questions about what they're hearing from federal government. And they're just, want a little bit more information. In the past, we've had patients that have readily accepted vaccines. Doc, if you recommend that vaccine for me, just go ahead and give it to me. But now we're seeing a little more questions. We are seeing some declining of vaccines that we hadn't previously seen, even among patients who had previously readily accepted vaccines. So I think it's something that we're seeing in the clinical setting, and something that we got to work with our patients to address.
And so I guess just to build on that question, when a patient comes to you to say the CDC says the vaccine isn't needed for everyone, but the Connecticut Department of Public Health says it is, what do I do?
So I think, we have to look at our patients individually, identify, what is this patient in front of me? What is their risk factors? What do we know about this vaccine? We have to acknowledge their concerns. They may be hearing concerns about potential adverse events relating to vaccines. But I think we also have to really acknowledge the risk of the infections themselves. I think that's something that unfortunately recently has become overshadowed by concerns about vaccine-related adverse effects. That we're losing sight that these infections that we're trying to prevent really do have serious consequences. And if I'm looking at a patient in front of me, particularly a patient who may be a little bit more vulnerable, maybe a little bit more around individuals who may be more vulnerable, I think we really have to take that into account also as we're trying to make a recommendation that's in the best interest of that patient.
Well, Commissioner, I think this does reflect in terms of what you've been sharing earlier too. Your agency is crafting a very different message from the federal government and RFK Jr.'s CDC panel. So adding to the conversation here, right? How does the public know who to trust?
It's a real challenge, I think, for people right now to know who to trust. But what I would say is, as an example, after the ACIP meeting last week, we had the American Academy of Pediatrics issue a statement, and there were dozens upon dozens of medical societies who signed on to that statement. So at the end of the day, we have to think about people who have spent decades of their life training in medicine, in infectious diseases, in pediatrics, in public health, across the entire spectrum of the healthcare universe, who are coming down and reaffirming where science has taken us up until now, versus decisions that were made in that meeting where there was no data presented that reflected the reason to change the decision. The reason to change the decision was that people have concerns over giving a vaccine early within the first 12 hours, first day of a child's life. I did not hear of information presented that would actually give credence to the idea that there is harm in doing that. And I think one of the other things that I'm very challenged by what happened in that ACIP meeting is that other than the votes that you mentioned, there was a vote to say that children who receive the first vaccine should then have a blood test. So another invasive procedure, a blood test to check on whether they had mounted enough immunity before giving subsequent vaccinations. Now, the reality is there's been a lot of talk about doing randomized trials, about looking at the data more closely. There are no data to support that a serology done, or no data that I'm aware of, that a serology done in an infant's life is going to reflect lifelong immunity to hepatitis B. The studies that have been done, we have achieved the schedule that we have right now because of data. This decision was not based on data.
I want to take a quick moment and grab a caller, Christine, who's calling in from Glastonbury. I believe this question might be for our doctor. Christine, go for it.
Yeah, sure. So, I've been reviewing the data on data.ct.gov for vaccine exemption rates by school in our state. And I noticed we have a few schools in our state that are still allowing religious exemptions despite our state mandate, and they seem to have very low vaccination rates. Are the local health departments in our state, in those areas with those schools, and the hospitals close to those areas, in addition to our state public health lab, are they ready? Do they have the capacity for a potential large-scale outbreak if it should happen? Right, in those areas where we do have those low vaccination rates in those schools? Like, do we have the capacity for mitigating, stopping? Will people follow the mandates for quarantine, isolation for those diseases? I'm just curious if we're prepared for that.
Thank you for that very astute question. I feel like you should work at the Department of Public Health. That's the type of data that I look at exactly for the reason that you are describing. So I just want to clarify a few things. So first of all, although religious exemptions are no longer possible, children that had them before the law went to effect were grandfathered. And so there are some who are still in place. New ones are not allowed. And so some of those schools may reflect that. The other thing I would mention on that is that we have partnered with our local health departments to make sure they are aware of schools in their communities where they have lower rates, and have worked with them to try to have vaccination campaigns in those areas specifically to target communities where there may be lower rates. Having said all of that, we have the highest immunization rate for measles in the country right now at 98.2%. Connecticut is number one for kindergarten age children. And we have prepped and prepared for an outbreak for the last several years because we've been seeing outbreaks around the country. So as you mentioned, between our state lab, our local health departments, the state Department of Health, we are ready and prepared to deal with an outbreak should one happen.
Thank you so much for that question, Christine. And got limited time here. Got some questions here for Dr. Banick here. What can public officials do to support yourself and your fellow doctors in their messaging, especially during these times?
So I think, we lean on our public health officials to provide us as clinicians guidance. But I think communicating with the public is really a critical role. Acknowledging concerns that the public has, identifying where this misinformation may be coming into the public thinking, and being able to address those concerns. We do that clinically. We provide guidance to our patients individually. But I think the public health department also has a key role in messaging sort of the counterpoints to a lot of the negative messaging that's out there about vaccines. So, and I think, Connecticut does a great job with that. And I think we need to really encourage that.
Well, of course, these are conversations that you're having, ongoing conversations you're having with your patients. And if fewer people get vaccinated, how real is the risk to your patients who are immunocompromised?
So I take care of a lot of immunocompromised patients, and I really think about them. I think, we do what we can to protect them, but they may not be able to respond to vaccines themselves. So we rely on the public to have that immunity to sort of lower the rates of these viruses and other infections circulating in the community. And I think vaccine is a big part of that. So, I worry about my patients that either can't be vaccinated because of their medical conditions or may not respond to vaccines. And we do lean on the public to maintain that immunity. I think messaging that to the public is also really important to protect sort of all of us.
Well, we've been talking about your patients. What about patients' families? So are you doing this not just for your own patients, but also for the people who are around them?
I think that's a key message. I think of a patient who I saw yesterday who is very immunocompromised, and speaking to their family members, their caretakers about the importance of them being vaccinated as well, I think is a really critical message to sort of protect not just the individual getting the vaccine, but also reduce the risk of infections around them.
And Jason, I have a final question for you as we're going from the past to the future. Any final messages that you would like to let our listeners or leave with our listeners today?
Sure. It's a reminder that these policies that have developed over generations have been thoughtfully, rigorously developed. And there's a mountain of evidence supporting how we've thought about vaccines and how we've continued to think about vaccines leading to the present day. And it's important to put that context into keep that in mind when we hear about some of these really rapid fire transformations that are happening and are proposed to be happening with our vaccination policy, and turning to the kinds of groups that have been stewarding this work, in some cases for decades, I think will be a really critical way to navigate what is undoubtedly a turbulent time for vaccines here in the U.S.
You've been listening to Jason L. Schwartz, who's an associate professor at the Yale School of Public Health. Thank you so much, Jason, for joining us today.
Thanks for having me.
You're also listening to Dr. David Banick, who's the head of infection prevention at UConn Health. Doctor, appreciate your time as well.
Thank you.
And of course, Dr. Manisha Jutani, who's the commissioner of the State Department of Public Health. Commissioner, always appreciate your time.
Always appreciate being here.
I'm Catherine Shen. Today's show is produced by Sujata Srinivasan, who's our senior health reporter. Our technical producer is Dylan Reyes. Download Where We Live anytime on your favorite podcast app. And thank you all so much for listening, and stay healthy, everyone.